Good morning. It's a pleasure for me to be here again. I was at the BAU last year, so it's a real pleasure. The meme tool that we will share with you is something new, and I would like, in just a couple of slides, try to explain to you what it is. This is a number of papers published and references in PubMed from 1962 to 2012. And I doubt everybody is able to read everything on prostate cancer only. The knowledge is increasing, and the more we learn, the more we publish, finally the less we know. And that's a problem. To help us, we have guidelines. Guidelines are made in a very structured way. You know there are level A, level B, and level C. I'm sure you all know that. But guidelines usually gives you some clear advices on very specific situations. For example, in castrate-resistant prostate cancer, there are guidelines explaining that first-line treatment should be that or that. Second line could be this or that. But they never show you what is a specific indication for a specific patient with a specific condition. The knowledge we have and the guidelines we have are all based on randomized controlled trial, should be only based on randomized controlled trial, at least for grade A recommendations. Randomized controlled trial is perfect. You define very precisely the target, you define very precisely the population, you have most of the time a very clear answer, and so for this specific predefined population you have a very specific answer. It's a yes or no. Sometimes it's a maybe, but then it's not a grade A recommendation. And at the end of the day, if you have a patient that fits exactly in the predefined situation, you know what is the best way to do. However, most of the time, patients in real life do not fit in a real case as defined by a randomized controlled trial. And that real-life data. Real-life data are what we are facing every day. They are very high external validity, but a very low internal validity. That is exactly the opposite of the randomized controlled trial. So we have a problem. We have very clear answers for very specific situations, and in real life, most of the time, it's totally outside these situations. Because of that, the Mirror of Medicine, which is a teaching part of the ISECAM. ISECAM is a non-for-profit organization which is supposed to teach, to conduct trials, to report meetings, and Mirror of Medicine is the educational tool of that, was launched online. It's an online program which is intended to combine the best evidence from randomized controlled trial and from guidelines, and the best evidence from everyday practice. MBA, it's medical everyday experience, what we are facing all the time. And this has to be combined, and it has to be combined through a very organized way, the Rung UCLA method. It's very simple. It's a very structured method. You combine evidence-based with expert opinion. But the expert opinion, there's not only one expert, there's a group of experts, and the experts defined for a precise situation what is, in their opinion, the best way, and they rank each question from 1 to 9. And this is summarized, and this is compared to answer of a panel and answer from you. So you have experts' opinions, they are combined with guidelines opinion, and sometimes they can be a little bit of a difference. All this is put together, and finally this finalized in a Mirror of Medicine teaching course, which is a web application. And the web application, again, is a combination of evidence-based from randomized controlled trial plus experts' opinion. There is a group of experts. The expert opinion is not the answer from one single guy. When you have a very big name, and all other names, a very big name very often tells you that's the way to go. Even if you disagree, it's very difficult to fight. And sometimes the very big name might be wrong. If you put all this together, there's no very big name. There's an informal consensus of a group of people. And that is Mirror of Medicine. Again, it's a teaching course. So far, that's the tool, and we would like to highlight with Gert 2 models of the tool. The first one is for locally advanced and high-risk non-metastatic prostate cancer, and the second is castrate-resistant prostate cancer. What we would like to highlight to you is what's behind the tool, how it works, and what it could offer to you in terms of teaching. Gert?
Good morning also. I first want to say that I give this lecture also on behalf of Steven Jonio, who is momentarily not in our country, so that's the reason that the radiation oncologist is here. And secondly, if the panel agrees, I would like to have that we have interactive discussions, because not all answers will be as clear as we want them to have. Now, the first module, and probably the most interesting one, is the module on high-risk non-metastatic prostate cancer. The expert panel in this situation consists of 12 international, what we call experts, and they went through the case and they give their advice by giving a point from 1 to 9. And then we expanded this expert panel vision to 84 specialists who we considered as being real specialists in high-risk prostate cancer. And then the specialist opinion and the opinions of the experts were compared to each other. And then you can, as a participant in this MIME module, you can yourself go through the questions and compare your own vision or your own answer with the answers of the expert panel or the survey. And now we will also add your answers to the questions today. You can vote, and then we will compare what you as an audience from Belgium have said and compare that to the expert panel and the participants. Now, the urologists, you can see them over here. I will not go through them, but you can see that they are all quite known urologists in prostate cancer. Also, radiation oncologists are very well did very well contribute to the panel, and we had also 2 medical oncologists in the panel, so well spread over the different subspecialisms. Now, first question, you should answer 1, 2, or 3, whether you are a resident, a neurologist, or something else. Something else can be everything. Yeah. I'm something else. I would be something else. Yeah. Voilà, okay, so I have 70% of the people in the audience are urologists. Okay. And then the second question is in which kind of work setting that you work. You can read the answer yourself. So please vote again, or well, not vote, please push the right button. Okay. So this means that more or less 90% is working in a hospital, clinic. Voilà. So let's go to case number 1. This case is a patient with a Gleason score that was less than 8, but on the clinical rectal examination and the magnetic resonance imaging was it a clearly T3 disease without seminal vesicle invasion, PSA between 10 and 20, good general condition, good life expectancy. So this is the patient, the first case. And the question is now, what would you do? And you have 5 different answers again. You can read them and you can vote, and then we will compare your voting to what the expert panel and the 84 Euro specialists have answered. So please vote on this case. Okay. It's very, very good, and I'm very happy to read that the last possibility. Hormonal treatment alone is not considered really appropriate. Now let's compare this now with what the experts has been said. Now you can read over here that the international survey, they considered surgery and long-term androgen deprivation therapy with external beam radiation as appropriate. And most of them considered androgen deprivation therapy alone as not appropriate. For radiation therapy alone and radiation with short course hormonal treatment, it was a little bit more uncertain. The expert panel, you can see on the right side what they considered as being appropriate. It was surgery and external beam radiation with long-term androgen deprivation. And you can see that the survey matched quite well the expert panel. And if you look at the results that you have voted, it's also the case surgery a lot, and you see that both the international survey and the expert panel consider this as appropriate, and external beam radiation, whether or not combined with long-term hormonal treatment, scores about 30%. Now, we have changed this patient, and this guy now has a Gleason score that is higher than 8 or equal, has no seminal vesicle invasion, his PSA is above 20. The question now is, will this change your attitude? So you can vote again. And if yes, maybe we can discuss why it would change your attitude. And we can also discuss what is missing on the treatment choices. It has changed the attitude a bit. Hormonal treatment alone has disappeared completely. Very good. Also, radiation therapy alone is only 6.7%, which is good because it's probably not really an appropriate choice. Surgery is still there, but a little bit less than it was on the former patient. Now, let's go to the panel guidelines now and the expert panel guidelines. So this we have had. And now you see that the expert panel still considers surgery and external beam radiation plus long-term androgen deprivation therapy as appropriate. Radiation therapy alone and short-term androgen deprivation therapy is considered more inappropriate than in the former patient. I think this is because this patient is at a very high risk profile, while the former one was moderately high risk profile. Something that is not present, and we can discuss this or later on, is the surgery. It should not be, I think, radical prostatectomy, but it should be plus extended lymph node dissection. So this is something we should add probably in the survey the next time. But anyhow, again, in Belgium we have a score. You can see it. Well, it was hormonal treatment was considered inappropriate. It got 0%, and surgery and external beam radiotherapy together by you audience scored more than 90%. So I think that the Belgian knowledge on this matter is quite good and impressive. So this is the first case. I don't know, are there any questions or suggestions or things you disagree with? No? Then I hope that, that you liked my model. Other questions from the panel? No? Okay, Nicolas, then we go to the second one. Thank you.
Okay, now we are turning to the castrate resistance status. Very simple situation. Again, you have exactly the same experts that were selected. A survey that was conducted exactly the same way as Gert said. It was conducted during the last PROSCA meeting. So we assume that people attending this meeting were interested in prostate cancer, and you will vote again. You have here the names of the expert panel, and probably you know many of them, and some of them are members of the EU guidelines group for prostate. So that's the first case. He has a good performance status, PS 0 or 1. He has no bone mets, no visceral mets. He has lymph node mets. He was not treated with a previous docetaxel, so it's a first-line castrate-resistant patient, and he's totally asymptomatic. And here you have the question, what would be your first choice in terms of treatment? CRPC, PS1, node positive, only. Please vote. And the question is the first choice. Okay, can we have the slides from the experts plus the survey to compare? Not far from 40% of you selected abiraterone as first choice, and only 20% selected docetaxel as first choice. And here you have the international survey plus the expert panel. It's of interest to see that few of you considered enzalutamide to be a first choice, while it was suggested to be accepted by the experts as an option. I will go a little bit later on that. So there's a difference. If you perform the web application at home and you answer this, and you would like to know why they selected enzalutamide as first choice and you did not select that, there's a problem. Or why did you select docetaxel? As you see, the expert panel suggested that it was uncertain, and 25% of you selected docetaxel as first line, while the survey considered docetaxel not to be an option for the majority. So the discrepancy. So we would like to have the answer behind all these statements, and that's where the tool, the web app, is effective. So it's a little bit different. Again, good PS status, but this time he has bone mets, he has visceral mets, he has no node mets, he is not yet treated with docetaxel, and he's totally asymptomatic. Good performance status, asymptomatic, bone plus visceral mets, not previously treated with docetaxel. And could we get the questions? What would be your choice? You have a lot of compounds, except the fact that just wait. It was not part of the question. It could be add, of course. The question is, what would be your first choice, just because of informatic?
Okay, because the patient has bone mets also.
Yeah, absolutely agree. But what would be your first choice? So first choice, half and half, docetaxel and abi. 7% selected enzalutamide before chemotherapy. Very simple. We don't have any data yet. We have something, but it's not yet published, not yet even presented. So we don't have anything. I'm surprised that some of you considered denosumab to be first-line treatment in this case, but that's how it goes. What could we see the survey plus expert opinion? How long do we have? Till 15? Okay, here you are, the survey, the expert panel, and as you see, the expert panel considered abi to be appropriate, enza to be uncertain. It's uncertain very simply. We don't have so far any data on enzalutamide first line. And personally, I'm surprised by this answer. I would have said inappropriate. So could we see what is behind enzalutamide on the web? That's a difference between, if I would have voted, I would have seen that, I would be surprised. So I would like to know why the panel selected enzalutamide to be uncertain. Can we go to the web? So if you go to the web, I would like to show you, I selected this case especially for that. You have green, red, yellow, and sorry, can you, okay. And enzalutamide is neither green nor red nor yellow. It means that it's not yet accepted neither by the FDA or the EMEA. And this was an improvement of the website based on the last year. At the beginning of this year, the end of 2012, enzalutamide, there was some answer. But in practice, it's not available. It's not approved. So even if you would like to use it, it's not approved. Totally different. PS2, only lymph node mets, no prior docetaxel, totally asymptomatic. PS2, nodal mets only, no previous treatment apart ADT. What would you do? These are the questions. And we might agree something is missing. I fully agree, but let's say, to be simple, the patients request something be done. So a lot of people selected ABI, and you will see, if I could have the survey answer and leave this screen there, if it's feasible, to have the survey there. So ABI is considered to be uncertain, while most of you selected ABI, surprising, and enzalutamide is considered to be uncertain by the expert, and again, there's no data behind that. Zoledronic acid, not an option, okay. Carbametoxantrone, not an option, and docetaxel, uncertain. PS2, what is behind that? What is behind that? Why was docetaxel considered to be uncertain and not appropriate? Could we go to the website and click to docetaxel? You have the evidence-based from the randomized trials. You have the everyday clinic. All this is put together. All this is put together to Mirror of Medicine. At the same time, it's checked all the time if there are new clinical trials that are published, there are new guidelines that are published. They are put again in the Mirror of Medicine website, and the website is living and it's improving. And of course, if you're using it, you might send questions to the web requesting, why didn't you select this kind of doing things, for example, doing nothing and just following the patient. So we feel that it might be a very helpful tool to have it. To have it, it's very simple. Just go to mirrorofmedicine.org and you'll get everything you need to register. And thanks to sponsors for this session, it will be totally free for you to log in, to register, and to have all the courses. What I showed you and what Gert showed you is a part of the courses. There are also very, very detailed courses explaining what is a locally advanced disease, why should it be treated that way in this way, based on randomized trials. But then you go to the modules what we showed you with when you define PS status, Gleason, grading, and so on, and you select it. This is half of the tool. The second half of the tool are the textbooks where everything is written. You don't need to print the pages on the screen. And all this is for free in Belgium because you're very happy, because you are a very nice sponsor that sponsored the session. And as you see it, it's totally independent from the sponsors. The sponsors don't have anything to say in what is behind the evidence. It's totally independent of the sponsors. Thank you.